Hello everyone. I am Docsaab and I am honored to speak with you today in emergency medicine and critical care. Optimizing every aspect of cardiopulmonary resuscitation is a paramount. Today we are going to delve into a crucial yet often overlooked area, mechanical ventilation during CPR. Specifically, we will explore what we call the six dial strategy, a structured evidence based approach to ventilator settings when an advanced airway is in place during cardiac arrest. This strategy aims to standardize care, reduce clinician workload, and ultimately improve patient outcomes. Let's begin by setting the stage. When patients suffer a cardiac arrest, our immediate focus, as per guidelines from organizations like the American Heart Association and European Resuscitation Council, is high quality chest compression and early defibrillation. Ventilation plays a critical and supportive role. While securing an advanced airway might be deferred initially, it becomes essential in prolonged resuscitation or when hypoxia is the primary cause. Once an advanced airway such as endotracheal tube or supraglottic device is in place, continuous positive pressure ventilation is delivered without pausing chest compression. This is a critical paradigm shift from earlier practices. Now, regarding how we ventilate, studies such as prospective international studies of 122 cardiac arrest patients have shown that both bag valve resuscitators and mechanical ventilators are equally effective in terms of blood gas measurements. However, in the high volume, often chaotic environment of an emergency department, especially with fewer trained personnel, mechanical ventilation offers distinct advantages. As highlighted by Weiss, mechanical ventilation allows the airway manager to focus on other vital tasks like chest compressions, defibrillation, or diagnostic efforts to find the cause of arrest. It also mitigates human error by providing consistent program ventilation parameters which can be difficult to maintain manually over time. Despite the clear advantages of mechanical ventilation, a significant gap exists. There are currently no evidence based guidelines specific to mechanical ventilator settings during CPR. This means clinicians often rely on general critical care ventilator settings which may not be optimized for the unique physiological demands of cardiac arrest with ongoing chest compressions. This lack of standardization can lead to variability in care and potential suboptimal ventilation strategies. The six dial strategy was conceived to fill this void. It is pragmatic, concept-driven approach that synthesizes available evidence to propose specific mechanical ventilator settings, particularly opt for CPR. Our goal is to simplify ventilator management, reduce cognitive load, and minimize human error, thereby allowing healthcare providers to concentrate on other high-priority resuscitation tasks. This strategy is also easily adaptable for patients who experience an in-hospital cardiac arrest and are already receiving mechanical ventilation, providing a seamless transition into the CPR ventilation protocol. Let's move into the specific settings starting with our first dial, positive and expiratory pressure or PEEP. In typical critical care, PEEP is crucial for improving oxygenation by recruiting collapsed alveolar spaces and reducing intrapulmonary shunting. However, the physiology of CPR is distinctly different. During cardiac arrest, with open chest or even closed chest compressions, an increase in alveolar volume from PEEP can significantly raise intrathoracic pressures. This elevation in intrathoracic pressure can severely impair venous return to the heart during the vital chest recoil phase of CPR, ultimately reducing cardiac output and coronary perfusion pressure. Therefore, our recommendation for the six dial strategy is to set PEEP to 0 cm of water. This aims to facilitate maximum venous return and optimize cardiac filling during the chest recoil phase. While one non-randomized study involving 290 in-hospital cardiac arrest patients did show higher rates of return of spontaneous circulation with 5 cm H2O PEEP, this finding lack multivariate analysis of other confounding covariates influencing ROSC. Given the clear physiological concern about the impedance to venous return, we advocate for zero PEEP during CPR, though we acknowledge that more robust human studies are needed to definitely support this recommendation. Our second dial focuses on tidal volume and fraction of inspired oxygen. Current resuscitation guidelines recommended a tidal volume of approximately 600 ml of pedals during cardiac arrest. To overview this on mechanical ventilator, we suggest a tidal volume of 8 ml per kg of ideal body weight. This specific volume helps to minimize CPR-induced ventilation perfusion mismatch, ensuring that the delivered air reaches perfused areas of the lung, albeit with significantly reduced cardiac output. Equally critical is the oxygen concentration. We recommended setting the fraction of inspired oxygen to 100%. The rationale here is to maximize oxygen delivery to the tissues. An observational study involving 145 in hospital cardiac arrest patients found that higher arterial partial pressure of oxygen during CPR were associated with improved hospital admission rates. While we aim for normoxia post ROSC, during active CPR, maximizing oxygen availability is key to mitigating cellular damage from ischemia. The third dial addresses the respiratory rate. This is an area where well intentioned efforts can actually be detrimental. Hyperventilation during CPR is a common occurrence, often driven by the urgency of the situation. However, hyperventilating a patient in cardiac arrest can have severe negative consequences. It dramatically increases mean intrathoracic pressure, which in turn reduces venous return to the heart, increases lung volume and pulmonary vascular resistance, and consequently decreases cardiac output and coronary perfusion pressure. These effects directly counteract our efforts to maintain cerebral and coronary perfusion. Considering that the cardiac output generated by chest compression is only about 10 to 15% of normal, a very high ventilation rate is not necessary and in fact harmful. A reduced ventilation rate is sufficient to maintain an adequate ventilation to perfusion ratio. Therefore, we recommended a respiratory rate of 10 breaths per minute for adults during CPR with a tracheal tube. While this is a weak recommendation based on low quality evidence, the physiological rationale for avoiding hyperventilation is robust and widely accepted. Now for dial 4, the maximum peak inspiratory pressure alarm. During CPR with an advanced airway, ventilation is delivered asynchronously with chest compressions. This means it is inevitable that inspiratory breath from mechanical ventilator will occasionally coincide with the chest compression. When this happens, the chest compression significantly increases the intrathoracic pressure. If the ventilator's Pmax alarm is set at a typical physiological range, say 35 to 45 cm of water, the ventilator may interpret this combined pressure as excessively high and terminate the inspiratory breath prematurely. This will prevent the delivery of the intended tidal volume. To ensure consistent tidal volume delivery despite ongoing compressions, we advise increasing the Pmax alarm setting to 60 cm of water. This higher threshold allows the ventilator to complete its inspiratory cycle even during compression. It's important to note that while this setting is necessary for effective ventilation during CPR, providers must be vigilant about the risk of barotrauma with elevated pressures. The maximum allowable Pmax is typically considered to be 80 cm of water. Therefore, individual patient titration and careful monitoring are still crucial. Dial 5 focuses on the ventilator trigger. Most modern mechanical ventilators have sensitive triggers designed to detect patient effort and deliver a breath in synchrony with patient's spontaneous respiratory drive. However, during CPR, the chest recoil phase following a compression can generate a negative intrathoracic pressure that mimics patient's inspiratory effort. If the ventilator's trigger sensitivity is too high, it can mistakenly detect this chest recoil as a patient demand and deliver an additional inappropriate breath. This unintended breath delivery can lead to several problems. It can induce hyperventilation as discussed earlier and potentially worsen gas exchange. A porcine study demonstrated that when the ventilator trigger was turned off, there was significantly lower minute ventilation volume and mean airway pressure coupled with higher aortic blood pressure, coronary perfusion pressure, and end tidal carbon dioxide. Therefore, our recommendation is to set the ventilator trigger to off. This ensures that breaths are delivered purely based on the set respiratory rate, independent of chest compressions. If the option to completely turn off the trigger is unavailable on your specific ventilator, a pressure trigger of minus 20 cm of water should be used as an alternative, making it less likely to be activated by chest recoil. Our final dial, dial 6, addresses the inspiratory to expiratory ratio. This setting is crucial for ensuring that each delivered breath has sufficient inspiratory time while also allowing adequate time for expiration. Current recommendation, even for manual bag valve ventilation, suggests that each breath should be delivered over approximately 1 second. Given our recommended respiratory rate of 10 breaths per minute, which means 1 breath every 6 seconds to achieve a 1 second inspiratory time, we calculate an IE ratio. 1 second of inspiration out of 6 second total breath cycle translates to an IE ratio of 1:5. This means the inspiratory phase occupies about 16 to 17% of the total breath duration. This ratio provides adequate inspiratory time for gas delivery and allows for sufficient expiratory time, preventing air trapping and its associated negative hemodynamic effects during CPR. While the six dial strategy offers a structured approach, it's vital to acknowledge its limitation. Mechanical ventilation itself carries an inherent risk, including barotrauma, volutrauma, and ventilator associated lung injury, which could be exacerbated by the altered physiology of CPR and the elevated Pmax settings we discuss. Practically, not all emergency departments have readily available mechanical ventilators, and even when present, staff may lack the specific expertise or comfort level to apply these advanced settings efficiently during a high stress resuscitation. Furthermore, the strategy is largely conceptual, drawing on physiological principles and limited observational data. The paucity of robust large scale human studies specifically evaluating these settings during CPR remains a significant hurdle. These are critical considerations for implementation. A critical point to emphasize is the transition after successful resuscitation. Once a return of spontaneous circulation or ROSC is achieved, it is absolutely imperative to immediately change the ventilatory settings from the six dial strategy. The goals of post ROSC ventilation are very different. Current guidelines for post ROSC care recommended a lung protective strategy, typically involving low tidal volume ventilation, such as 6 to 8 ml per kg of ideal body weight, with carefully titrated levels of PEEP. The aim here shifts from maximizing oxygen delivery during arrest to achieving normocapnia and preventing secondary brain injury and lung damage. All other parameters such as trigger, Pmax alarm, and IE ratio should be reverted to their default physiological settings and adjusted dynamically according to the patient's specific requirements. Continuous monitoring of blood gases and lung mechanics. This transition requires an active and thoughtful clinician input. In conclusion, the six dial strategy provides a concise, evidence informed framework for mechanical ventilation during cardiopulmonary resuscitation. By standardizing these six critical ventilator parameters: 0 PEEP, 8 ml per kg tidal volume with 100% FiO2, or respiratory rate of 10 per minute, a Pmax alarm of 60 cm of H2O, turning the ventilator trigger off, and IE ratio of 1:5, we aim to optimize ventilation delivery during ongoing chest compressions, minimize complications, and ultimately contribute to better outcomes for our cardiac arrest patients. This strategy underscores the importance of continuous effort towards evidence based practice in critical care. While promising, it highlights the need for ongoing research, particularly robust human trials, to further validate and refine our approach to ventilation during CPR. Thank you for your time and attention, guys. I hope this presentation has provided valuable insights. I am now open to your questions, comments, and discussion. Please feel free to reach out to me if you have any further questions or thoughts. And please like, share, and subscribe to the Docsaab's Diary.